Have you ever wondered what analgesia should you pick for your patient who is in acute pain in the hospital? Should I try acetaminophen or NSAIDs or go for opioids? In this video, I will show you how to pick the right analgesia in real-world hospital settings. Acute pain can be mild, moderate, or severe. The most commonly used pain assessment scale in the hospital is the numerical scale, where we ask patients to rate their pain from 0 to 10, where anything above 6 is considered severe. Let's start with mild pain. This is pretty straightforward. Oral acetaminophen alone or in combination with a low-dose oral NSAID can be used. An ideal mild pain regimen would consist of acetaminophen 650 mg orally every 4 hours as needed, or ibuprofen 400 mg orally every 4 hours as needed. The patient's nurse should give one of these two options, not both together, and alternate if they wish to. Personally, I prefer the sole use of acetaminophen in mild pain category. How about moderate pain? For moderate pain, we use high-dose oral NSAIDs with or without low-dose IV acetaminophen. IV NSAIDs can be used here. In such a case, oral NSAIDs should be discontinued. An ideal regimen for moderate pain would consist of naproxen 500 mg orally twice daily as needed, or ibuprofen 600 mg orally every 6 hours, or ibuprofen 800 mg orally every 8 hours as needed, or acetaminophen 650 mg IV every 6 hours as needed, or ketorolac 15 mg IV every 6 hours as needed. Let's move and talk about severe pain, which is frequently encountered in inpatient settings. This is the category where opioids should be reserved for severe pain only, including oral and IV opioids. This may seem odd, as a lot of hospital pain protocols include low-dose oral and IV opioids for moderate pain. Please avoid that unless there is a contraindication to use acetaminophen and NSAIDs. Why am I saying this? Adding opioids for moderate pain likely will lead to unnecessary and avoidable use of opioids. Just imagine your patient is having moderate pain based on the assessment scale, and you have the option to pick between a low-dose opioid or an NSAID. Most of us will unconsciously lean toward picking the stronger analgesics, which is opioid here, although a dose of naproxen would have been probably adequate. So unless there is a contraindication to use NSAID or acetaminophen, reserve opioids for severe pain only, please. But does that mean opioids are the only agents available for severe pain? Of course not. High-dose IV acetaminophen and IV NSAIDs are pretty effective in severe pain as well. So an ideal regimen for severe pain analgesics would consist of IV acetaminophen or IV NSAIDs, oral opioids, or IV opioids. I will go for IV NSAIDs or IV acetaminophen first, oral opioids second, and IV opioids are our last resort if patient's acute pain remains inadequately controlled. Remember that NSAIDs are first-line analgesics in the following conditions. Renal colic, IV ketorolac in particular is effective here. Musculoskeletal pain like arthritis pain, pleuritic type chest pain, rib fracture, muscular strains, etc. Incisional post-operative pain, and again ketorolac is particularly effective here as well. And remember, acetaminophen is particularly effective in most types of headaches, whether alone or in combination with caffeine. Now, which opioid should we use and what dose? There is a lot of important information here, so please allow me to defer all of this to the next videos. I will also discuss NSAIDs and acetaminophen along with opioids, so stay tuned. Now, in persistent severe pain, where the patient keeps requiring recurrent doses of opioids despite treating or while treating the underlying cause of pain, we need to try to reduce the pain level with other means and consequently reduce the need for IV opioids. So what are these means? First, adding scheduled oral acetaminophen or oral NSAIDs. Remember here to discontinue their IV equivalents. Second, adding gabapentin. And third, adding a scheduled low-dose oral opioids can be considered if previous measures did not help reduce the use of IV opioids. Let me give you an example here. A 64-year-old lady was admitted with a pelvic fracture. She's in severe pain, and her severe pain regimen consists of the following: ketorolac 15 mg IV every 6 hours as needed, oxycodone/acetaminophen 5/325 mg orally every 4 hours as needed, and morphine 4 mg IV every 6 hours as needed. You reviewed her chart and found that she received 12 doses of IV morphine over the last 3 days. Her nurse reported that IV morphine is the only thing keeping her pain under control, and she asked you if there is anything we could do to help her pain control. Of course, the first thing I do is check if the patient has received IV ketorolac and or oxycodone/acetaminophen, or if the nurse just jumped to IV morphine. If they have not been tried, I will ask the nurse to try them first and assess the response. If they have already been given with inadequate response, then we can do the following. Add scheduled high-dose oral ibuprofen like 800 mg of ibuprofen every 8 hours, or naproxen like 500 mg naproxen every 12 hours, or acetaminophen 650 mg every 4 to 6 hours. Second, I will add gabapentin and start probably around 100 mg twice daily. And third, if that remains inadequate, we add a scheduled oral opioids for a few days while escalating the gabapentin dose. Please remember this about the use of acetaminophen and NSAIDs together. Do not combine oral and IV form of the same medication or the same class within the same severity category. For example, don't use oral naproxen and IV ketorolac together for moderate pain, or oral acetaminophen and IV acetaminophen together for severe pain. Second, combining acetaminophen at doses higher than 2 grams a day together with an NSAID is not more effective than using an NSAID alone, and might be associated with a higher risk of gastrointestinal complications, so keep that in mind. And third, the total daily amount of acetaminophen should not exceed 4 grams a day, including all forms of acetaminophen, whether oral or IV, as well as the one combined with oral opioids. I will discuss this in more detail next video. Now, there are other options to consider in severe pain cases. First, regional blocks performed by surgery or anesthesia can be helpful in rib fracture or post-operative pain. Second, ketamine can be considered in severe pain refractory to opioids. Third, dexamethasone can be considered where swelling and edema are suspected as a contributing factor to the pain, like in disc herniation or cancer-related pain. Local anesthetics like lidocaine patches are not that effective in acute severe pain management, but they can be used as an adjuvant therapy to other analgesics for superficial musculoskeletal pain. And muscle relaxants can be considered when muscle spasm may contribute to the patient's acute pain. Before we finish, we just talked about the analgesic strategies today, but I highly recommend you watch my previous video, 5 must-ask questions before giving analgesics in inpatient settings. The link is provided below. In that video, I went over the appropriateness of analgesia, and I also discussed drug-seeking behavior, when to suspect, and how to deal with it. In the end, if you would like to receive a PDF summary of this video and future videos, make sure to sign up with the link provided in the description field. If you have signed up already, the summary should be delivered to your inbox 24 hours after the video is released. And remember, sharing is caring, so share this video with your colleagues if you found it useful. Thanks for watching, and see you soon.